Jagdish, I will just start off and give it over to Sushant and then to Balachandran.
Yes, please.
I mean, you will give one line of opening remarks and hand it over to Balachandran.
What I suggest is you start off. There's no need for me to speak anything at all.
No, one line. Welcome. That's all. One line. Only one. Yeah.
Right. So doctors are live now. I can see that the attendees have started coming in.
Yeah. Let them come.
Yes, sir.
Good evening. Wonderful to see so many of you here today. And we have an excellent session which is going to be presided by our own Dr. Balchandra. And the coordinator is going to be Dr. Sushant Mane. The faculty for today is going to be Dr. Omi Narayan and Dr. Indu Khosla. And today's topic is going to be sleep. And Dr. Subramania will now take over and give a few more tidbits before we start the actual show.
Okay. Thank you, Dr. Jagdish. Himadri, we will wait for a couple of minutes as the people are logging in. And I will just be apprising them about RESPINAR for a minute, for 60 seconds or so till I can see the people logging in.
Yes, sir. Yes.
Dear friends, please note that your Monday and my Monday and everybody's Monday 9 p.m. is for the chapter, and it's for respiratory chapter. And if you ask me, is it for respiratory chapter? I will tell you it's for pediatricians, not for the chapter, because 90% of your pediatrics is respiratory. And therefore, if you are a pediatrician, by all means, you are informally respiratory chapter member for us. Only thing is you have to complete couple of formalities. Contact me. I will make you officially and formally respiratory chapter member. We want to see you on Zoom very soon. So that's our aim. So that's one. Second thing is that this RESPINAR will continue as long as you people nurture it, encourage it, and support it, and not just attend it, but see that each one of you make another 50 attend the RESPINARs, and only then the science percolates. And thanks to Corona for making the flow of knowledge uninterrupted and seemingly unimaginable, and at the doorstep of every pediatrician. It's something amazing. And I think everybody now has some time also to introspect what they have done in the past. I at least I have learned in the last 5-6 months more than what I have learned in past 10 years, to be very honest with you. And this is therefore the times are very nice. We have fixed 9 p.m. because you can comfortably have your dinner while watching the science. I don't think you can have any other time. And what a great beginning for a week with some lessons from the pulmonary medicine. So this is the introduction to RESPINAR. Please WhatsApp to my number. Whenever you are not getting the link from anyone, if you are getting only posts or flyers, please save my number. I'm just repeating it for some of you, but all of you will be knowing. But for the sake of communications, I'm just referring to you 94482079993. Please WhatsApp to me. Even if you have doubts, you WhatsApp to me. What was pleasant to see for today's session was that there were 15 to 20 questions that were asked even before the session started. Dr. Jagdish, this is for your information that, and I don't think in the times of when the webinars fatigue is there, people ask questions before the event that we want answers for them. And the questions have been already sent to Indu and Dr. Omendra for today's discussion. So they are going to cover it up. What gives me more pleasure is that after being secretary, when we started the RESPINAR for a couple of events, Dr. Sushant Mane, one of our enthusiastic younger brother of mine and executive member, took over the complete responsibility of coordination of this meeting. He consulted Dr. Omendra Narayan, Indu Khosla, everyone, and arranged everything, and clapped to him from myself and Dr. Jagdish for making this event. So you will see him at helm of affairs of today's RESPINAR. Before I would hand it over to Dr. Sushant Mane, I wanted to acknowledge the presence of our senior most respiratory chapter president, Dr. Balachandran, from Chennai. Namaste, sir.
Namaste, namaste, namaste.
Good evening.
Good evening.
Balachandran, so there could be some of the youngsters who are watching. If we are all pulmonologists today, it's because of the legacy of the roots of lung that were sown in Chennai by really committed pulmonologists from Chennai. But for them, we wouldn't have been there talking to you all, because it's that family from starting from Dr. N. Somu, Dr.
Subramaniam.
L. Subramaniam, and Balachandran sir, and then Vijay Shekaran, and so on and so forth. I can name, it will take 5 minutes for me to name the entire family. Now it's a very big grown joint family. They are doing excellent job in respirology. So thanks to you, sir, you represent the entire family today for us. And he has been the past president of IAP National Respiratory Chapter. So therefore it's our privilege to have him. And today, the speakers will be Dr. Omendra Narayan. He is born Indian, got graduated in Mumbai. Then, for thirst of knowledge, he flew west and settled well in UK, only to tell there that we Indians who are coming here are better than you. You know, that kind of message he has given in UK. And nice to see a youngster who is grown up and, a very friendly person. The knowledge and is seemingly high. And thank you for the dedication in pulmonology that you have been over years. And we're very happy to have him today. And you know, the person who settled in India try to see that I will not go east or west, but I will be in Mumbai and see that the pulmonology takes its roots, and have that kind of commitment from none other than my great dear senior friend of mine, Dr. Indu Khosla. She is there for anything, any help that you ask for the respiratory chapter. So she is also going to speak some kind of issues apart from what Dr. Omendra Narayan is going to speak on sleep medicine as well. My dear friends, before you go to sleep, watch the sleep from all of them. And it's not easy to sleep, you will realize. And it is very difficult, but not to sleep. And to make the children sleep, it's not that easy. And to understand a child sleeping, it's much more difficult. None of us know that we were slept, but we know that we slept only when we get up in next day morning. Till then we are half dead. I don't think, if you ask, the greatest pleasure and the greatest time that you have is when you sleep. And if you ask me as a professor, the greatest time I will have in my life when I sleep in seminars of postgraduates. And with these couple of words on introduction to sleep in general, let me hand it over to Dr. Sushant Mane, who is going to coordinate, and he will hand it over to Dr. Balachandran sir. And then I will not come in between the science and you. These couple of minutes of my opening remarks were only to see that all the people log in and attend. So I was covering up your time for you rather than opening up my remarks. And with these words, we are very, very thankful to you for coming to attend webinars, and after such a Mahabharata of webinars. And thank you very much. Log in every night, Monday, 9 p.m. Over to Dr. Sushant Mane, our executive committee member. He is also professor of pediatrics from JJ Institute, one of the prestigious hospitals in Mumbai. And he has his work on tuberculosis particularly and pulmonology are awesome. He has the largest collection of MDR TB, if correct me if I'm partially correct, but he has a very good collection of MDR TB. We are going to have some brainstorming session from him later sometime in the respiratory chapter as well. Over to Dr. Sushant Mane.
Thank you, sir. Thank you for that really wonderful introduction of mine. And good evening to all the panelists and as well as the attendees. So I won't take much of the time, because as sir said, we should not be sleeping in a sleep session. I would just like to welcome all of you on the behalf of the respiratory chapter our today's chairperson, Balachandran sir, who will be taking all the proceedings forwards. Indu madam, who we have always looked upon, especially from Mumbai, who is a pioneer of pediatric pulmonology from Mumbai. She'll be talking today upon interesting cases. Definitely her talk is later than Omi's talk. Omi will be taking over first. He'll teach us about the normal physiology of sleep and common sleep issues. Now, as far as Omi and I are concerned, we met 2 years back, and then it was like an instant connection. It is called as the GMC connection, which Dr. Jagdish sir will also, relate to that. And when Subbu sir told me that, can you get Omi for sleep, I was like, oh, I will just have to ping Omi on WhatsApp and it will be done. And that is what he did. I just pinged him, and within 10 minutes he agreed, okay, Monday night I'll be there and I'll be speaking live. So considering all this, it was not a very big deal or a very hard work as sir is projecting that I have done a lot of work. But yes, I've done my bit to contribute to the Respinars, and I will definitely continue doing it. So over to Dr. Balchandran sir. Sir, can you please start and take the proceedings? Yeah, thank you.
Thank you, Dr. Sushan man, for the opening remarks. I take it a honor bestowed upon me by Dr. Jagadish Chinappa and Dr. Subramania to moderate today's session. It's a great honor indeed. Today's Dr. Subramania has talked a lot about all these things, and I don't want to talk again. The sleep. You may think, many people will think, what is sleep? 2 days I was reading about sleep. My wife was talking, telling, what you are reading about sleep? What is this? What is this? Something wrong with you? I was going on and reading, and then I learned, oh God, many things I have not learned. I'm so ignorant. We turn the page. We know only nightmares and then the night terrors and other things, sleepwalking and all. After reading the sleep in detail, I know sleep indeed is a separate chapter, separate speciality. I learned. At the most we know, as a pulmonologist, we know the obstructive sleep apnea. That's what we know. All the things, other things, we ignore it. Now I learned, I read it again. So I'm now inviting Professor Omi Narayanan to talk on common sleep problems in children. I hope he'll tell us what is really sleep, what we understand sleep. I'm going to tell the different features, what are the things you should look for, what a pediatrician should be aware of, when should be referred to a person, whether it should be handled by a pediatrician itself or to a neurologist or any specialist like that. He will going to tell us. Over to Dr. Omi Narayan. Good luck.
Thank you, sir. And thank you very much, everyone, Prof. Subramania, Sushant, Professor Chinappa, to invite me. And I know that Sushant said it was only last week, but I'm always I really like to contribute whatever I can contribute in the Indian respiratory chapter, because I am born Indian and I'm still really feel privileged to be part of this important meeting. So in next half an hour or so, 40 minutes, I'm going to mainly cover the physiology side of things and then talk about few cases. And I know that and Dr. Khosla is going to talk in much more detail about individual cases. So I hope people can see my screen now.
Yeah.
Yeah.
Yeah, it's fine. Clear.
Right. Okay. So just making sure that it goes in the slideshow. Sorry, having some technical problems here.
Take your time, sir, no problem.
I'm not too
Sir,
sure.
So if I can help you, could you please stop sharing once and try again? Probably
Okay.
it's the network.
Okay.
Yeah.
Let me close and then restart. Maybe that will help.
You have the backup slides with you?
Yeah, just a second. Let's see again. I'm just trying now again.
Yeah, it's
Okay.
coming.
Yes, sir.
Yeah,
We're able to see your slides.
yeah, it's working now.
Yeah, it's working.
Okay, right. Sorry about the technical problem.
No, just
So,
Omendra, please, if you don't mind, you press once and I mean, see if it scrolls further. Second slide. Yeah, it's fine.
right. Okay.
Yeah.
Brilliant. So, yeah, I'm going to mainly talk about the physiology and then kind of briefly touch on classification. But as we are talking about, the respiratory chapter, and as respiratory pediatrician, what I see mainly is obstructive sleep apnea. So I thought that it will be nice to just briefly touch on some different kind of sleep studies that we can do. But the one which is easily available is oximetry. And if we can know how to have like some basic concepts in the interpretation of oximetry, that might be very useful as pediatricians. So, what is sleep? And we know, as you know, Professor Balachandran was saying that he was reading about sleep, and that's really right, because what I remember from my physiology lecture, which was 25 years ago, was probably pretty much half an hour on sleep. And surprisingly, that hasn't changed in last 25 years. And I'm talking about even in graduate schools in Manchester, where I'm very actively involved. And the sleep lecture on sleep, and in terms of physiology, what we learn is less than an hour in entire curriculum of 5 years of MBBS, what you learn. So kind of, unless you are really interested and unless you come into pediatrics and start reading more and get exposed more, you don't know much about sleep. But we know that from kind of what we are talking about, what is sleep, it's a reversible state. And in the introduction, Professor Subramania said that as we go to sleep and then wake up in the morning, and that's very important. And that's what the anesthetists, they do as well. They put you in deep sleep, but they have that capacity to wake you up. And that's very important, because if you don't wake up, that's not very nice. And it is extremely, extremely complex in terms of the physiology side of things and the behavioral side of things. And what I've written over here in my last line, most people will be lying down and sleeping, but not necessarily. You might see that people do nod off if they are sleep deprived, even in sitting posture, sometimes even standing. And majority of people will have their eyes closed. So why do we actually sleep? What I would suggest is, if you haven't watched the TED Talk from Matt Walker, you do the YouTube kind of, it's easily available on YouTube, and go and watch that. It's a 19-minute video. And I feel that right from kind of medical students, which I use his opening line when I'm teaching medical students on sleep. And how he opens the talk is that he says people who sleep less, men who sleep less than 5 hours, they have small testicles. That's his opening statement in a talk of sleep. I'm not going to spoil the kind of, his talk, but I would strongly recommend that you go and watch that. And he talks about the various kind of, he has written books. He's a British neuroscientist who's now based in California, and he talks about various aspects, various physiology side of things, why we sleep and why it's important. Some of the things that I have listed over there is in terms of the memory consolidation, which I feel is extremely important and which we didn't know. And I feel sad that as, like, even as medical students, when we were trying to cram up in the last night, and not actually recognizing that if I don't sleep, that whatever I'm cramming up in the last night, I won't remember next morning to regurgitate in my anatomy and physiology viva. So that's very important. Just because we don't know how important it is that when you sleep, how from your short-term memory it goes into your long-term memory. And that's what the memory consolidation is. We talk about, from your CD it goes into the hard drive of the computer. It's extremely important that that's the time when your brain is maturing and it's getting repaired from the wear and tear. You know that people who don't sleep well, their immune function doesn't regulate very well, and they get frequent colds, they can get frequent chest infections, and their immune function is to some degree impaired. So let's come to sleep wake regulation cycle and why this is important. And this is like a two process model. And if you see this curve, there is process S and process C. So if I have to explain, so this is quite complicated, but if I have to explain in simple terms, sleep is regulated by two major processes. One that promotes sleep, which is process S, and it's mainly driven by adenosine, which gets accumulated when we are awake. And process S is like it increases throughout the day. So as you're awake, it keeps going up, up, up. And then kind of, as you can see over here in the curve, by around 10 to 11 p.m., it's at maximum. And it's just a kind of cartoon depiction that will vary according to different age. And the process C, which stands for the circadian system, that actively promotes alertness throughout the day. And thus opposing the buildup of your homeostatic sleep drive, which is your process S. And that kind of runs in, as you can see in the graph, and the maximum gap is around in the night time, 10 and 11. And this two system is extremely important to maintain your sleep system. Because if there is a problem in either of them, then you have a problem in your sleep cycle. And we know that the circadian system is very well coordinated through the environment, through the light and dark cycle, and melatonin is extremely important in maintaining that. So that's kind of the sleep wake regulation. And there are several other theories, but this is the most acceptable theory that we know about. So coming to the sleep cycles, and what we will call this as a sleep consultant, we will call this as a hypnogram. What we know from your physiology, if you remember, that there are two major kind of sleeps, non-REM and REM. And non-REM stands for when the REM stands for rapid eye movements and non-rapid eye movements. The non-REM is generally in three stages. Initially, we used to call stage 3 and stage 4, but we know that there is no essential difference between these two stages. And what happens is that non-REM and REM cycle alternate cyclically, and we don't know why this is kind of, why they cycle like this. But if we know that if there is an absent cycling, then it's related with the sleep disorders. And a healthy adult or a healthy child, they will go through various stages of non-REM, and then from non-REM 1 to 3, then to their REM sleep. And essentially the non-REM sleep makes up pretty much almost around 80% of your sleep cycle, and 20% of your sleep is made by the REM. So we always start with non-REM sleep, and then we pretty much towards the end of the sleep, the REM cycle is much, much more consolidated. So in the first couple of hours, your REM might be only for a few minutes, but if you miss out, so if in the hypnogram you can see toward the latter part of your sleep cycle is predominantly REM sleep. So if you miss, and why that is important for us, because the most common disorder that we see, the obstructive sleep apnea, that is predominantly a REM disordered problem. And if we know that if you have missed the main problem, what we will see is toward the latter half of the night. So I'm not going to spend much time about different waves and what we see and how we interpret the non-REM and REM sleep. But what is most important is that you remember that in REM sleep, what happens that our muscles become atonic. There is rapid kind of eye movement, and it's extremely, extremely important that this is, although we think that this is a passive, our brain is passive, is actually not. When you look into the brain waves, the brain activity is as much as when we are wide awake and very, very alert. So the REM sleep is extremely important, and very important to remember that that happens toward the latter half of your sleep. So the $1,000,000 question is, how much sleep do we actually need? I'm a big fan of Sadhguru, and I kind of agree to what he says, except for one thing where he talks about sleep. And I think that when Sadhguru says that, many people can manage on 4 hours of sleep, I think that is like a bit of superhuman to be able to manage on 4 hours of sleep on every night. So for adults, when we talk about adults, most adults will sleep, if you can see in this age group, between 7 to 9 hours of sleep is needed for most adults. Uh, Many people can manage with 6 hours, and some people will require up to 10 hours as well to have that recovery phase. But majority of us will require around 7 hours of sleep, consolidated sleep throughout, to make sure that we are getting enough sleep. But as you can see in this graph, when the newborns are there, but in the first 6 months, pretty much they don't have an established circadian rhythm. Their sleep wave cycle is very, very erratic, and they will, and that's why they will sleep in daytime as well. And the sleep, if an average sleep for newborn will be 14 to 17 hours, but as we can see that it gradually declines, and predominantly preschoolers and school age children, they need anything from 9 to 12 hours of sleep. Some children will manage between 7 to 8 hours, but some children will require more than 13 hours of sleep as well. So if you're sleeping less than that, that's not enough, that's inadequate. If you're sleeping more than that, that's too many hours, and then as well there might be a problem. Now, so what happens as we continue growing? There is no good news, I'm afraid, because as we continue to grow and as we continue to get old and older, are not only the duration of sleep kind of goes down, also we know that the REM sleep, if you can see in the beginning, in the neonatal period and infants and children, as you can see, the predominance over there is of REM sleep. It keeps on going down as we continue to age. So in one of the pre-questionnaires, which Dr. Subramania just sent 2 minutes before we started this talk, was one of the question was, what are the numbers we are talking about in terms of the sleep disordered breathing? And if you read various literatures, the number varies, but the one of the common thing that we know, that's pretty much 1 in 4 child or children will have some kind of sleep problem, and that could be a behavioral problem, that could be a physiological problem, or that could be some actual primary sleep problem. So that number varies, and that number varies depending upon the society as well, and the societal norms as well, which I'll come to in my next couple of slides. But the primary sleep disorder, if we're talking just about OSA, the numbers are around between 4 to 5% of children. So 1 in 20 children can have symptoms of obstructive sleep apnea. But when we look into behavioral side of sleep problems, and particularly bedtime resistance, not liking, when you ask them at 9 o'clock the time to go to bed, and they're resisting sleep and they're fighting sleep, that those numbers are quite common, and you can see that 1 in 5 children, they can do that. So what do you think, that is your child getting enough sleep? And that's the kind of question what I feel that every pediatrician should be asking. And if you're seeing them in your clinic as a part of your holistic kind of history taking, one of the questions, and that might just open a can of worms. Parents might just bring various issues over there, because what I feel is that we don't ask enough, that is your child getting enough sleep or not, and we completely ignore the sleep side of things. So if we look further into epidemiology, and these numbers are mainly from UK, but what we are saying is that more than half of the boys and girls, they are sleep deprived. And sleep deprivation is not only in toddlers, but what we are seeing more and more in school going children. Adolescents, we know that they sleep less, and but if we see in the on the right side of the graph, we can see that on that chart, India is not written over there, but what we can see that in terms of the more developed nations like United States, Australia, England, we are talking about more than 60% of children, they are sleep deprived. And these sleep deprived children are not doing well in their academics. And when we are talking about the academics, this survey was looking into how they're performing in school and doing maths and science tests. And these children were sleep deprived. And that's really worrying, that why we are talking about more than half of these children being sleep deprived. So this was a kind of recent article in from NHS. They're saying that last year under 16s we had more than 10,000 children requiring hospital admission related to sleep disordered breathing. That's kind of really worried. And when we are talking about insomnia, a teenager always being tired, this is quite common. They go to bed with their mobile, and they are now, COVID has obviously posed several problems, but they are, if we talk about many of the adolescents and teenagers that I know, they watch Netflix and they're binge watching Netflix, and they compromise on their sleep, and that affects their daytime kind of activity and academics. So is this a problem just for a Western world? I don't think so, because I was looking into some articles and from India, particularly trying to find out what's happening over there. And several articles were there. Children's lack of sleep is a hidden health crisis. This is from last year, February last year, from Chennai, and then kind of looked into other article, and they all are saying that in India the children are not getting enough sleep. And this article says that India is second last on the list of people how much sleep they get. Another article where in this article Dr. Khosla had given her kind of recommendation as well, and she talks about parents take note, Indian toddlers are not sleeping right, and they are not sleeping enough. And there were various kind of reasons attributed towards kind of lack of sleep and why they're not sleeping enough. But some of the things that were given were screen time, uh, academic pressures, parental pressures, and also parents working late, parents coming home late, and that has a knock-on effect on children. They don't go to bed early. If parents are coming from work at 10 o'clock in the night time, then they're having some time with their children. So obviously that child is not going to go to sleep before 11 and midnight. And just remember, pre-COVID, these children were all going to school, and the school always starts at 7 8, and so they have to wake up early regardless of what time they were going to bed. So why is this a problem, and what happens if you don't sleep well? So I've talked about your kind of, your memory consolidation, your immunity side of things, your academics. So unlike adults, they don't, adults might just fall asleep in front of you on train, while commuting, in office, in the clinic. But children, they don't show those symptoms. Children, they kind of become hyperactive. Their behavioral problems, they come across with behavioral problems. They get labeled as ADHD, autistic spectrum. We get lots and lots of referrals from our psychology services, because these children who otherwise appear normal, but they have been labeled as naughty child and ADHD and whatnot. So they get referred to look into, are they sleeping well or not. But as this slide shows you, some of these children are overweight, and it's not kind of very clearly known. We know that if you're overweight and obese, then you will have obstructive sleep apnea. But then which one is the chicken and egg? Sometimes you don't know, because we know that if you're not sleeping well, then you're likely to get overweight, because you tend to overeat, because it dysregulates your leptin. Many of these children will have psychological issues. Some of them can be depressed. If you're not sleeping well, particularly in adolescence, while going to school, coming back, playing, they're more prone for injuries, because they just can't concentrate. They will have more vehicular accidents. I've already talked about more number of infections, and humongously, they have massive effect on their academics. And you can see that they actually, if they're not sleeping well, they can never perform very well at school, which is extremely important, because they are our future. So I thought I'll just put one slide, because uh, I think that with COVID, everything has gone in kind of, there is no routine. And for children, the most important aspect is to have a routine. When they go to school, there is a routine. Now the schools are closed. Many of them are having some online lessons. Many of them are having no lessons. Parents are working from home, so there is no kind of there is no fixed pattern to anything, and that has had a massive effect on the sleep as well. So it's not only children, but we are seeing more and more problems in adults as well, and there are lots and lots of things we are seeing, that they are, even adults are struggling with their sleep. So it's really hard at the current times, when we have so much of unpredictability and uncertainty. So in the kind of next few slides, we're going to talk about sleep problems. If you read the textbooks in the ICD-9 classification, there are more than 80 sleep disorders listed. But we're not going to talk about them. In the revised classification, which happened in 2001, they have mainly put them into 4 major groups. And they are dysomnias, which is primarily that we deal as pediatricians, and respiratory pediatricians, which is mainly kind of sleep disordered breathing. You can divide them into intrinsic and extrinsic sleep disordered breathing, narcolepsy, circadian rhythm disorders, delayed sleep phase syndrome. So those kind of disorders are called as your dysomnias. I've labeled their Ondine's curse as well, where you have congenital central hyperventilation syndrome. Whenever they sleep, they forget to breathe. Then the other classification is parasomnias, which, sleepwalking, sleep talking, sleep terror, night terrors, those kind of things comes as parasomnias. And then some of the parasomnia, majority of parasomnias are non-REM related, which we have talked about, but some of the parasomnias can be in REM sleep as well. Then the third major classification is sleep disorders associated with mental and other medical disorders, and primarily with neurologic disorders. And that could be related with mood disorders, with sleep related epilepsies, problems due to reflux. These children are not sleeping because primarily there is a medical disorder rather than problem with sleep. And then the last is miscellaneous classification, where if you have been unable to put into one of these categories, then you can say that they could be like short sleepers, long sleepers, sleep-related laryngospasms, neurogenic tachypneas. Those kind of disorders will come in there. So how do we, get into the root of the cause. Obviously, there is history taking. As doctors, we have to take a good history into sleep. But then you can do sleep studies, and there are various different kind of sleep studies that you can perform in a tertiary center or in a district general hospital. And so I'm not going to kind of spend much time over here, so I'll move on. But a normal kind of, if you're doing a polysomnogram, it involves multiple channels, and child has to come to hospital for that. And the data that you get looks something like this. But I was looking into, because like with the COVID thing, what has happened that our sleep lab, we had to close as well. And previously we were just doing one sleep study at home, which is multi-channel. But now with the COVID, we have been doing many sleep studies, predominantly all sleep studies at home now, and they are multi-channel sleep studies. So unless a child requires a hospital admission and they require polysomnography, we're not doing that in the COVID era. So I was looking that, do we actually do it in India as well? And I found that on the ResMed website, it said that the people are performing, or at least they have the facility of home sleep studies, and it just costs 2,000 rupees, which I felt that was an amazing kind of, when we compare to an average tariff of around 900 pounds that we charge for a sleep study. It's an extremely profitable business in UK and in NHS, that with even with home sleep studies, we charge 600 pounds, and hospital cardiorespiratory polygraphies, we charge more than 1,000 pounds. So this, we are talking about 2,000 rupees. So I don't know. I mean, I was going to ask Professor Subramania and Dr. Khosla that how are we actually doing it in India, or is it just the adults physician that they are doing it for various things, or are we actually doing it for children as well? And if not, then is there a scope for that? But maybe we can discuss that in the question answer session. So uh, next few slides on OSA, because that's what is the most common thing that we see. And in history taking is very important, and I'm sure Dr. Khosla is going to agree and is going to talk about this in her talk as well. Nighttime snoring, gasping, restlessness, pauses in breathing, sweating at nighttime, abnormal posture, trying to keep their neck open. These are some of the common things that parents will mention. But they will also mention that most of the time the child, because they have enlarged adenoids and tonsils, they're trying to breathe through open mouth. And that leads to kind of dry mouth, asking for drinks, waking up several times, either at night or in daytime, asking for several times drinks because they're always feeling dry. And we have talked about worsening academics, and in extreme cases, we also see failure to thrive, that a child who is not thriving. And as you can see, if there is enlarged tonsils like this, or an MR scan in the coronal section, we are seeing that the tongue falls back. The first number over here shows a normal airway, and what happens on the right side, normal airway when the tongue falls back and when we are sleeping. But when you see in what happens in OSA with the enlarged palatine tonsils, which is labeled as P, there is hardly any airway there, leading to hypoxic events at night time. So one of the questions in the pre-seminar was that, are all snorers kind of, how important is snoring? Snoring is very, very important if you're talking about OSA. But pretty much I would say that if they're not snoring, it's unlikely for them to have OSA. It's not that they can't have, but it's unlikely. But on the other hand, if they are snoring, not always means that they will have OSA. And in this graph, that's what I'm trying to show, that in the bottom over x-axis, it says AHI, which stands for apnea hypopnea index, a number of times you are having hypopneas and apneas every minute. But what it tells you is that if there are various classifications, AHI of 1, 5, 10, and that essentially will put you into numbers of whether you have upper airway resistance, milder form, moderate form of OSA, or severe OSA. And kind of, this numbers will only be generated if you're doing a sleep study on that child. So I thought I will spend some time in talking about oximetry, which is the easiest test to do in terms of doing and ruling out or ruling in sleep problems. And that we do pretty much more than 1,000 every year. We do cardiorespiratory polygraphies around 1,000 a year, but we do more than 1,000 of oximetries in our children, because this can be done by nurses in the community at home, and the data that comes in can be extremely important. So what we need to remember is that oximetry has a very good positive predictive value. So if there is a problem and it picks up a problem, then you can rely on that, but doesn't have a very good negative predictive value. So if the history is suggestive, on examination you're worried, and the oximetry comes extremely normal, then you might have to think about that, yes, these children do need referral in tertiary center for a cardiorespiratory sleep study, polysomnogram, or whatever is the availability in a tertiary center. So that's what kind of is important to remember. And we presented some of our data from our children last year at ERS, that some of the other markers that we were looking for, so this was presented by one of our registrars, uh, is called as delta index. And what we saw, that if the delta indices is more than 0.46, that can itself be an indicator of an OSA. Other thing that we look for, and I'm sure many of you would be aware, is called as ODI, oxygen desaturation index. And if that number is less, normal is less than 4 per hour, so that essentially tells me that how often this child every hour is desaturating below the median level. So if in this kind of snapshot, you can see that the median saturations are already low, 91%, but this child is desaturating more than 20 times every hour. That is an abnormal study. So that is suggestive that this child is showing signs of obstructive sleep apnea. So there are other markers that you can see in when you're looking at oximetry. If you have saturation line like the first line, straight line, it can rule out that there is no evidence of OSA. But even without looking at the numbers, if you see lots of clusters of desaturation, that is telling us that every time the child goes in REM sleep, becomes hypotonic, and probably is desaturating, becoming hypoxic, it might not show you arousals or micro arousals, but these are extremely important. Sometimes, if it is inconclusive, then again, a referral is needed at tertiary center to respiratory pediatricians for proper sleep study. Some other slides, and kind of just coming to last few slides, and I'm talking about over here is a 5-year-old presenting with snoring, uh, reduced time kind of daytime activity, and tiredness in daytime. You do an oximetry, and these are classical desaturations. Every time you see they go in REM sleep every 90 minutes and they desaturate, suggestive of obstructive sleep apnea. You do a cardiorespiratory polygraphy. These are the epochs that you will see. What we see is the flow becomes straight. There is no flow, essentially meaning that there is no breathing. There is no detection of airflow in your nose. That is telling that there is an apnea, but there is still ongoing movement of the bands of the chest and the abdomen. That is telling us, and that's related with desaturation over here, at least more than 4%, and that is telling me that that's an obstructive event or obstructive sleep apnea. So how do we treat that? A good trial done in US known as chat trial, when they looked into school-going age children, where they waited, what's called as watchful waiting versus adenotonsillectomy. There was no difference in both group in terms of the sleep study. But when they looked into their performance at school, the parental reported concerns in terms of what they do in daytime, there was much better outcome in the group where they had done adenotonsillectomy. So essentially, adenotonsillectomy is the first line treatment for children with obstructive sleep apnea if they don't have any other underlying health problems. If they're non-syndromic, if they're non-obese, if they're otherwise normal child, and they have evidence of obstructive sleep apnea, then adenotonsillectomy is the first line. And as you can see in the picture, large tonsils, obstructive airways, you remove the tonsils and adenoids, the airway becomes much more larger, and the airflow is improved. But in milder forms, if you're waiting, or if adenotonsillectomy is contraindicated, if they're extremely young, you're worried about GA, there are contraindications. In milder forms, you can use nasal steroids, montelukast, and those kind of things. There is some evidence it works in the milder forms. Children with cerebral palsy, they are extremely kind of vulnerable for various multifactorial problems in their tone, that they do have lots of obstructive sleep apnea, but they do not do very well with adenotonsillectomy. So some of these children will require nasopharyngeal airways in terms of managing their obstructive sleep apnea. Uh, so I would say in because I have a very kind of skewed view in terms of OSA, because I see children with complex morbidities, and many of these they will not improve with adenotonsillectomy, and essentially we will have to go to our second or third line, and where we will think about positive airway pressures, primarily CPAP, but many of the children with metabolic problems and neuromuscular problems, they will require BiPAP with a bi-level support with a backup rate. So looking for some other examples, this is an example from ours. A 14-year-old when has had a brain tumor removed, and since the removal of the brain tumor, parents have noted that otherwise he's well, he's in remission, there is no other signs, but he remains really tired in daytime, and when they have seen him kind of sleeping at nighttime, they have witnessed pauses in his breathing, and that can last for more than 20-30 seconds, and parents have been worried. So now this is important, because if we are suspecting that this is not an obstructive event and they could have a central event, then an oximetry cannot delineate, it cannot differentiate between an obstructive and a central event. So again, this will be an indication for referral to a tertiary center where they will have, they can do a cardiorespiratory polygraphy or polysomnography. And in this study, what we can see, that airflow is again blocked. So there is no airflow. So there is an apnea. We see that there are no movements in the respiratory bands or abdominal bands. So this is a central apnea event. So this is very different to obstructive sleep apnea. And again, but the effect is pretty similar, that this child is having lots and lots of micro arousals, having fragmented sleep, and feeling extremely tired. Now, this can be treated very easily because you remove the hypoxic drive, you give them a bit of oxygen, and their sleep study improves like this. And so that's very, very easy. But sometimes some of these children, because we see a lot of children with brain tumors who have been removed, sometimes they don't improve with oxygen, or sometimes they start retaining CO2, then that's contraindicated to give them oxygen because we are removing their hypoxic drive. In those children, we might have to put them on non-invasive ventilation with a backup rate. And as you can see here, their central apneas completely get resolved, and they have a normal sleep study. This is a kind of another example that we see in our sleep clinic, when an adolescent who wouldn't go to bed until 3 a.m. and obviously wouldn't wake up at right time to go to school. So this is what I talked about earlier in dysomnia. This is not obstructive sleep apnea. This is not central apnea. When you do a sleep study on them, they have a normal sleep architecture. So they don't have any desaturation. But when you do ask them to maintain a sleep diary, and you do something called as actigraphies, which is something like watch, leave them for a week and look at their sleep pattern, and you can see that in daytime they are sleeping and nighttime they're wide awake. What they need is a strict sleep hygiene, and what is something called as chronotherapy, where you want to give them excessive daylight and try to move their sleep by 1 to 2 hours every day over 2-week period to try to normalize that. And sometimes we have to admit them just for that, to normalize their sleep cycle. Last kind of second last slide, 10-year-old has sudden urge of sleeping in classroom, not doing well, has inappropriate behaviors, poor concentration, and this is narcolepsy. If you have sudden urge, is extremely rare, I would say. there are kind of links with certain vaccination as well, but we know that there is a deficiency of hypocretin. What they have is a sudden urge of sleeping, and they go into sleep paralysis. They can have hallucinations or a cataplexy. Very diagnostic. Again, if you're suspecting that, they will need a referral to a tertiary center because they will need a different kind of polysomnogram, and they have a very typical pattern what we see. So if you remember in the first slide, I said we always start with non-REM sleep and go in the REM sleep, but these children, they have sudden onset of REM sleep, and that's what SOREMS stands for on hypnograms. So if you look into their study, they start with REM and they suddenly go in sleep. And that's what kind of happens in narcolepsy. Treatment is again various kind of, you can give modafinil, sodium oxybate, but again, I would suggest that referral to a tertiary center would be extremely important. Uh, Restless leg syndrome, I think someone asked about kind of other disorders. Again, so there are some periodic leg movements, restless leg syndrome. Essentially, these children are kind of having lots and lots of leg movements. And again, it becomes important to do a sleep study on them where we are doing video recording, because the physiologist can look into their which way they are sleeping, what's the, so if their normal sleep architecture is normal, but if you look at the videos, they are moving kind of every few minutes, and they have various postures. The difference between PLM and restless leg is that one will happen in both sleep and awake, but kind of restless leg only happens during sleep. So I just wanted to kind of give you a run through a very, in 40 minutes time, a quick run through this talk. So my take home messages are that sleep deprivation is common and it's rising, and probably mainly due to, I would say, easy accessibility to mobile phones. We definitely didn't have mobile phones when we were growing up. We didn't have Netflix. We didn't have Amazon Prime. We were not addicted to Facebook, Instagram, and Twitter. So that has kind of, societal norms. It's now a normality that all teenagers will have phone, but that brings on kind of a problem. I would say that education is very important. People should recognize that there is a problem, then we can solve it. And education is important is by, if doctors are educated, if they know about the problem, then they can discuss that when parents are coming. We have to educate in school as well, to teachers and children. Strict sleep hygiene is extremely important, and no caffeine, no kind of caffeinated drinks, not going for electronics pre-sleep is very important. And for us as respiratory pediatricians, OSA is probably the commonest in preschool and early school children. That's it. Thank you.
Sir Omendra sir, if you can stop sharing the screen.
Thank you.
Dr. Indu Khosla, should we take the questions after your session? That would be better, isn't it?
That will be better,
Because you may
because
cover some
overlapping
of
will be
them.
there.
So fine, over to Dr. Balachandran sir. Sir, please, you can invite Dr. Indu Khosla.
1 minute. So I invite Dr. Indu Khosla, the famous respirologist from Mumbai. No conference is incomplete without her participation. She is a very knowledgeable person. She's going to discuss today on the interesting cases in pediatric sleep medicine. I think it'll be wonderful. Whatever the Vomi Narayana said, she'll be sharing what is the real problem we face in India. That will be more useful to our Indian participants, I think. Over to you, Indu Khosla.
Thank you, Dr. Balchandran, for those wonderful words. And I would like to thank the respiratory chapter, Dr. Jagdish Chinnappa, and Dr. Subbu, as we call him as Dr. Subbu, and I would like to call him that way because we're a friend. And of course, Dr. Omi, again, I share Dr. Sushant's opinion on Omi and how one conference we met and we clicked immediately. So he's really a wonderful human being, and I thank Dr. Sushant for organizing the whole thing. I just shared my screen.
Mhm.
Okay, is my screen visible?
Yeah.
Yeah, okay. So I'm going to take you through a couple of interesting cases, and I think I thank Dr. Omi for laying the background for me and making my task so very easy. And I'm sure I can actually run through a few cases because he has explained the basics so very nicely. You know, if you look at history, way back in 1837, Charles Dickens, in his book, The Posthumous Papers of Pickwick Club, he described an overweighted or hyper-somnolent boy. And the first publication on OSA came in 1889 by Dr. William Hill, and he described a child with OSA, and he called him the stupid, lazy child who frequently suffers from headaches at school, breathes through his mouth instead of his nose, snores, and is restless at night, and wakes up with a dry mouth in the morning, is well worthy of your attention of the school medical officer. So we have come more than a century after 1889, but I still think most of us are still sleeping over sleep, and we need to wake up and help these children who are having a problem. And today, the classification of sleep disorders has more than 80 disorders which have been described, which is not only OSA, but it is much, much beyond OSA that we have. And we have a whole list from insomnia to sleep-related breathing disorders. We have disorders of hypersomnolence, circadian rhythm disorders, parasomnias, and sleep-related movement disorders. Now, I think Dr. Omi has very nicely highlighted the importance of sleep because it affects almost every aspect of our life. It can affect our physical, cognitive, emotional, and social development. And we are most worried about the cognitive development in our growing children. It also conversely, children who have neurodevelopmental problems, like say children with autism or children with ADHD, they tend to have more sleep problems, and in fact, it makes their problem worse. So it is a chicken and egg story here. So we need to be more conscious when we are having children with autism or ADHD, and we must dwell into their sleep history. If you don't sleep well, your daytime behavior is going to be altered, and we all know it very well. If you have a busy night at the hospital, the next we are at our worst self. We are very irritable, we are groggy, and our mental functioning is not proper. So it is so important to have a good night's sleep, and it can cause a lot of morbidity, not only in cognitive but cardiovascular morbidity like hypertension, autonomic dysregulation, neurocognitive morbidity, depression, aggression, ADHD, growth impairment in children, and metabolic effects like insulin resistance, type 2 diabetes, and metabolic syndromes are all described with sleep disorders. So how do you approach a child who comes to your clinic you may suspect have a sleep disorder? But I think most of us, and that includes me, in our busy OPDs, we probably do not dwell upon so much on sleep history. So this acronym of BEARS makes it simpler for us to remember that sleep history important we need to take for all children. Of course, definitely for respiratory disorders, but also for all children who come to us. And it's very easy to remember. So what BEARS is bedtime issues. So you may have children who may not want to come to sleep. They may have bedtime resistance, or who may have difficulty in falling asleep. Or you may have children E who have excessive daytime sleepiness, obviously because they have not slept well the previous night. It could be sleep onset or sleep maintenance. You have children who may be awakening through the night. So you need to ask for awakenings, whether it was nighttime awakenings or early morning awakenings. What caused the awakenings? Were there any movement disorders which caused the awakening? Or were there any other night terrors, dreams, somnambulism, so many things which can cause a child to get awakened, right? Then we need to understand whether the parents have instituted a proper sleep hygiene in children. So the regularity and duration of sleep is of utmost importance. Just like we impress upon our children all other qualities, and I think, and all other necessary things for not only for development but also for good health. Sleep is one of the most essential things. So regularity and maintaining a good sleep hygiene is extremely important so that the child can have a good sleep sleep habits. Then, of course, not to forget snoring. It's not that normal children don't snore, and a good 3 to 15% of children will normally snore. But children who have snoring and who have drop in oxygen saturation, or who also have disintegration of their sleep, so that there is sleep impairment. So these are kids where the snoring is abnormal, and therefore we need to ask these histories. So all this when you have in your clinic, if you ask this history of bears, you will come to know how the child is sleeping or whether the child has a sleep disorder. And the parents may have some other concerns of special movements in sleep, which I think Dr. Umi fleetingly did mention about it, and I will dwell a little more about it. And whether the child is taking any medicine like anticonvulsants, etc., which could alter the child's sleep cycle. So these are very important when we approach a child who comes to us in our clinic and we want to take a sleep history. Now let me take you through some simple cases which we normally see in our clinic. So this is an 18-month-old child who is a breastfed healthy baby and is brought by the mom, that the mom is complaining that this child is not sleeping at night. We generally tend to brush away most of these histories. Don't worry, the child will sleep. But this mom is insistent and she says, my child wakes up at least 5 to 6 times at night. And the moment I breastfeed him or if I rock him, he goes off to sleep. So she's worried. She's actually concerned that she's read somewhere that this child is not sleeping well and this might affect the child's brain development. And she thinks that the child has a sleep disorder. So how would you approach such a case? So the first thing you need to understand is this a sleep disorder? Is that first thing that you need to ask yourself, and probably go a little more into the history of this child to understand whether this is a sleep disorder or not, or whether it is normal for an 18-month to get up 5 to 6 times in the night. Are these multiple awakenings acceptable at this age? Is the second question you need to answer. Is there a reason for this? Is it pathological? Is the child sleeping appropriately for it? The number of hours that he is taking. So Dr. Umi has shown you charts on what is the correct amount of sleep that we need to sleep at particular age. And then finally, can we help the mother and can we correct it so that even she has a good night's sleep? Or could we have prevented it in the first place? So I think the first thing here is, this is an 18-month-old. We should not dismiss the mother's concern. An 18-month-old getting up 5 to 6 times in the night is actually not normal. Now, we know of the REM sleep and the non-REM sleep. Infants, when they fall asleep, they generally, instead of going from the non-REM sleep to the REM sleep, they tend to get into the REM sleep faster. They have shorter spurts of REM sleep all through the night. In fact, 50% of their sleep is REM sleep. And they tend to make, when they get into REM sleep, they make whimpering sounds. They make sounds during arousals in REM sleep. And this is mistaken by most parents as awakenings. So these are not awakenings, but are arousals. So if you ask the mother very carefully, what is happening? Is the child actually getting up? If you go in detail of the history, she will say, no, he just cries a little bit. If I pat him, he may actually go back to sleep. Or if I leave him alone also, the child will go back to sleep. So babies can actually self-soothe themselves to go back to sleep. And this habit or this milestone has to be nurtured for a healthy sleep. So, but if we do not allow them to self-soothe themselves, we may convert them into something called as signalers. So they signal us, we react to their signals, and we give them props or associations which actually become obstacles of sleep through the night. So night feeding, breastfeeding, especially in a child about 6 to 8 months, one should actually stop night feeding. So night feeding becomes an obstacle for a good sleep through the night. If we use props like rocking the child, or some people tend to pat the child. So these associations also become obstacles for preventing the child to self-soothe. But we must also remember that some children may actually have some medical condition and which we need to rule out, which is preventing the child from sleeping. So it is extremely important that we develop a good sleep hygiene, and this is a developmental milestone. For that, we need to know that a 4 to 6 month old can actually sleep for 4 to 8 hours uninterrupted without taking a feed. About 6 months, a good 6 to 8 hours, a child can sleep through the night without taking a feed, and we must let them sleep. Because most mothers are in a habit of feeding the child 2 to 3 hourly. And if the child is sleeping for so long, they themselves are upset why the child is not got up, the child is not been fed, etc. Above the age of 12 months, he is like an adult and can sleep through 8 hours through the night without a feed. So these are the recommended sleep paths. I think Omi has already shown it. So I'll go through this slide. I'll go to the next slide. And we need to understand there are some medical conditions in infancy which can cause sleep issues in infant. We need to rule out reflux disease, which can cause the child to be irritable in the night and may be arching his back and maybe getting up frequently. Obstructive sleep apnea in an older child we need to look at if that is causing the child to get up again and again. Children with allergic rhinitis may have a blocked nose in the night, or children with asthma who may wheeze at night, and that may be obstructing the child's sleep. Some kids are colicky. And do not forget food allergies and sensitization and cow's milk allergies. We thought did not exist in our country, but I think we are seeing more and more cases. So we need to go through all these histories and rule out medical conditions which could be preventing a child from sleeping before calling it a poor sleep hygiene. So in summary, we need to nurture a good sleep hygiene, and it should start very early. So by age 1 year, the child should be sleeping well on his own and should be able to sleep 7 to 8 hours at a stretch. And quality growth, development, memory, and attention. Infants should sleep through the night, as I told you, by 1 year of age. We must eliminate all sleep drops or sleep associations, rule out medical conditions, introduce sleep coaching as early as possible. So it is extremely important even for the mothers. If a mother is going to be awake through the night, every night, she's going to have a lot of depression and psychiatric problems herself. And we need to keep a safe environment, and we need to have the child should be put in the same environment every day. So he's coached to sleep every day. The moment he reaches that environment of his nice bed, correct lighting, no noise, no screens, he will automatically learn to sleep himself. Let me take a second case. Now, mother brings a 15-year-old with complaints of headache. So we took the history. There was no diurnal variation. There was no vomiting following the headache. There was no URTI suggestive of any sinusitis, no trauma. Addictions, we looked at a 15-year-old. There were no scholastic issues. He was bright in class, no visual disturbances, no family history of migraine. He was well grown, blood pressure was normal, all pulses were well felt, no sinus tenderness, CNS examination, all other systems were normal. So we did not find anything positive. The parent was counseled, treated the child with analgesics. But the mother promptly came back after 1 week because the headache was persistent. But this time the mother cancelled the appointment and took a late afternoon appointment, saying that my child will not get up only before it is 12 o'clock. So that gave us a clue. So we need to take history of sleep in any child who comes to us with headache or any such problems. So what does this adolescent have? He has probably a delayed sleep-wake phase disorder, which is a failure to synchronize internal circadian rhythms to the environment light-dark cycle. So we must understand the physiology of sleep of an adolescent. So by the time the child is an adolescent, there is a little delay in the physiological delay in the circadian rhythm. So children, the onset of sleep for an adolescent is much later than when you compare it to another child. So they tend to fall asleep maybe at 11:30, 12, unlike a younger child who probably will sleep at 8:39 or 9:30 if you train the child properly. They also have a good increased sleep requirement. You must remember that growth occurs in sleep. So adolescence is a phase of growth. So therefore, they have an increased sleep requirement. And most of these adolescents who are under pressure to perform academically, tuitions, classes, etc., they sleep late, they have to get up early, and they're chronically sleep deprived. And that is one of the commonest reasons they can present to you with a headache. All right. There's also a change in the light exposure patterns because of social and behavioral factors. So most of the kids are on screens, the lights are on, and that light prevents them from falling asleep. And therefore, this also results in delayed onset of sleep. And this causes them to get late, and they also get up late because they need that sleep and they're not waking up early. So what one much late sleeping on weekdays results in chronic sleep restriction. So weekends come and all these adolescents are out. It further causes a sleep restriction, impairs their daytime function. It increases the risk of depression and even psychiatric disorders. How do you manage? So what's first most important is you must encourage physical activity in the evening. So something, if they run, if they play a sport, they're likely to actually get a little fatigued, and that would help them sleep early. One must avoid all kinds of screens at bedtime or any activity which is very stimulatory nature at bedtime. On weekends, they are bound to sleep late, but I think you must take a promise from them. Okay, you're going out for the night, but you have to still come back and get up early in the morning at the regular time. Maybe we'll give you a 30-minute extra. So that is how probably you can kind of bargain with them and prevent this disorder of their circadian rhythm disturbance. Gradual advancement of, and if you have to train them, you slowly, so if a child is sleeping at 1 o'clock, you maybe try to push it to 12:30 and try to push the waking up late by half an hour earlier. So gradually over a period of a week, 10 days, a month, one can change their timings. And those who have really found difficulty in falling asleep, a trial of melatonin, some studies have shown that melatonin does work. Melatonin 3 to 5 milligram 1 hour before bedtime, and exposing them to light in the morning. So we know the circadian rhythm works with exposure to light. You tend to get up. So you expose them to light in the morning, little melatonin in children. Let me take another case. This is my third case. Sorry, this is a 4-year-old with recurrent runny, itchy nose since 1 year. He's now complaining of nose block and is snoring heavily at night. The concerned parents have brought a video for your perusal, and this really helps. You tell your parents if your child is having any problem. Video. This is the video that the parents brought. So if you watch this child, he's pausing to breathe, he's finding it difficult to breathe, almost gasp for a breath. And that kind of awakens him, but not fully. So he's still asleep, but he definitely had difficulty in getting his breath, right? So this is classical for an obstructive sleep apnea. If you see even their posture, they will sleep with a head high posture. So in order to enable them to sleep better, so that the airways are kept open. So is it normal to snore? About 3 to 15% of children would be primary snorers. When will you worry about a snoring child? If snoring obstructs the child's ventilation, fragments his sleep, and causes hypoxia. This is a snoring that you would worry about. And there is an entity called as habitual snoring. We should be aware of it because children who have habitual snoring have a higher risk of an obstructive sleep apnea. And habitual snoring is defined as snoring at least 3 nights per week. And I think this slide, Dr. Naomi has also shown when do you suspect OSA. You could have nighttime symptoms or daytime symptoms. So typically, as I showed you in the video, the child will gasp, snort, will have an apnea, will snore, will have abnormal posture. He might awaken fully or still may be in his sleep, and then he may go back to sleep. He may have labored breathing, he may bedwet. And daytime, they may be sleepy, or in children, they may be actually be hyperactive. They can have attention deficit, morning headaches, behavioral problems, and academic deterioration. The most important pediatrics what we see are adenotonsillar hypertrophy, but mind you, there is no linear correlation to size. So here, size really does not matter. It's not necessary for it to be a big tonsil to obstruct. A small tonsil can also obstruct because it could also be the hypotonia of the upper airway, which can cause obstruction. Okay, obesity is another increasing cause for obstructive sleep apnea in our population, and other causes which reduce the size of the airway, impact the control, or cause the upper airway. And the list is endless. So you could have craniofacial abnormalities which can cause reduced size, or you could have a collapse of the upper airway in children with like Down syndrome or neuromuscular disorders, achondroplasias, Prader-Willi, etc. Cause a lot of obstructive sleep. So this child who was snoring, you saw the child, you advised a polysomnogram, but the mother was reluctant. She says, "Doctor, isn't the video self-explanatory? How will you counsel this parent?" Okay, so we do understand that polysomnography is not available. Dr. Omi was wondering whether it is available in our country. Yes, it is available in some centers in the country. We face the same problem as the West faces, getting a good pediatric trained technician who would actually sit down and read our polysomnograms. Our sleep labs are more adult centric, and pediatric sleep labs are still, I would say, still developing, and there is a long way for it to go. So it's a gold standard for diagnosis. It helps us actually quantify the amount of obstruction, and it also helps you follow up. So if you have a patient whose PSG is abnormal, you operate on him for a tonsil adenoid, and you may follow up to again quantify it and see how it's going. Are there any other investigations which can help? There are a whole list, but I will take you through each of them. Role of X-ray nasopharynx. There are a lot of fallacies, and I would not recommend that you do it for diagnosing an OSA. So the fallacies could be positioning, interpretation, and all. As I told you earlier, there's a poor correlation between size of the adenoids and the clinical presentation. Nocturnal pulse oximetry, Dr. Omi has already highlighted. It can be used when PSG is not available. Useful only when OSA is associated with significant oxygen desaturation. This is the McGill's criteria. It's positive if 3 or more desaturation cluster. A cluster is defined as 5 or more desaturations to less than 90% occurring in a 10 to 30 minute period. So if you have 3 or more such desaturation clusters, you're likely to think that this child has an OSA, and you can then proceed to do a polysomnogram. The limitation is that it has a low negative predictive value. So a child who may not desaturate can still have an obstructive sleep apnea. There are a lot of questionnaires which are available. There are questionnaires which are child sleep habit questionnaires. There are child sleep related breathing disorder questionnaires, and there are pediatric sleep questionnaires. So these questionnaires do help, but they have to be validated for that particular population for us to be able to use it. And this is the polysomnogram child, and if you typically see the child had multiple periods of apnea and hypopnea along with oxygen desaturation with those periods of obstruction and with increased thoraco-abdominal movements suggesting that this was an obstructive sleep apnea. So his AHI was more than 10. So he was advised a tonsil adenoid removal, but the parents said the tonsils regress with age and it is required for the child's immunity. Should we remove it or leave it? Or should let nature takes its course? Or is there any medical management? So these are the day-to-day problems we face when we have children like this who present to us with obstructive sleep apnea. So are there any long-term consequences if not treated? So I think we have all highlighted that there is a lot of neurocognitive abnormalities in children who continue to have obstructive sleep apnea. Okay. And the parent also asked that if you operate, doctor, will my child be completely cured? How will you answer such a patient, right? So medical management can be given to children who have mild OSA. Okay, so you can try a course of intranasal corticosteroids with or without LTRAs, which can be given for a period of 12 to 16 weeks, and it is known to reduce the AHI on polysomnogram, and it also known to reduce symptoms. But mind you, this is only for those with mild symptoms. So the chat study which Dr. Omi mentioned did show that children who have mild OSA could be managed conservatively, and it was only the ones who had OSA which was of a significant which AHI was more than 10 would definitely require more aggressive management. Now, even if you have done a tonsil adenoid removal, like in our kid, which was required because the AHI was more than 10, you need to follow up these kids. It is not that you have done the tonsil adenoid removal and your story is over. You could have a persistent OSA even after tonsil adenoid removal, and that's the reason why a polysomnogram done before is of great value. So if the child comes back to you again with the symptoms of OSA, and if the AHI is less than 5, you can just do a watchful waiting. You can also try medical line of management like nasal corticosteroids and LTRA. If the child is obese, you need to look at losing weight. And if the child has severe OSA, post a tonsil adenoid removal, then you may have to look at a positive airway pressure like a CPAP or a YPAP that may need to be given. And orthodontic treatment or orofacial myofunctional therapies or other surgical options in case it's a child with OSA who has other problems in the maxillofacial area. Let me take you through another case. A 5-year-old who came who was a known case of Down syndrome, and he was brought for frequent awakenings in the night and sleeping in odd postures. In fact, this parent told me that I have not slept at all because this child comes and sleeps on me, and he sleeps inside, and the child was heavy. And the way the child sleeps, that's the only way he sleeps. He says, if I move, the child gets awakened. So I am not getting sleep because this child cannot sleep in the night. So he was 30 kg at 5 years. He had all the features of Down syndrome. How do you manage such a child with Down syndrome who has probably features of obstructive sleep apnea? So 50% of children with Down syndrome without any even sleep related symptomology will have an abnormal PSG. So we need to have a very low threshold to screen children for OSA in Down syndrome. And if you look at the American Academy of Pediatric Guidelines, they recommend a polysomnogram to be done for all children with Down syndrome by the age of 4 years. And these are children who will require treatment more, means they will require probably a positive airway pressure like a CPAP or a BiPAP for treating them, because these are kids who are hypotonic and their upper airways are very collapsible. And so this was the PSG of this child. It showed clear obstructive apneas, okay, and with loud snorings. If you see here, the child was snoring very loudly, and this was the child who had to be treated. My next case is a 3-year-old boy who was brought by the parents for rapid weight gain and eating too much. He had history of delayed milestones, and their child had behavioral issues. Mind you, this parent did not complain of any sleep problem. They basically brought for weight gain and eating too much. On asking, they mentioned, yes, this child snores a lot and has disturbed sleep. He was a full-term normal delivery. He had an NICU stay for poor feeding. He had a BMI of 23, was short, had a narrow forehead, almond-shaped eyes, small hands and feet, undescended testes, scrotal hypoplasia, and he was hypotonic. I'm very, very sure all of you know the answer what this child would be, what this likely diagnosis would be. Yes, this child was diagnosed to have Prader-Willi syndrome. And infants, they present, the diagnosis can be done clinically, and now with the availability of genetics, it can very easily, we can come to a final diagnosis. So infants and toddlers will present with hypotonia, feeding problems, and failure to thrive. It's very important to remember that babies who come with feeding problems, hypotonia, because at this time, they're not even obese. And therefore, one can miss the diagnosis of Prader-Willi syndrome. Older children would have an increased appetite, obesity. If you do not restrict food to them, they will all eat a lot and they will become obese. They'll have decreased cognition, hypogonadism, and short stature. So this is the time the diagnosis is easy, but one must suspect for this child completely. All right, they tend to have a lot of apnea, central, obstructive, and they have excessive daytime sleepiness. So a polysomnogram in these children is a must. And genetic testing, you need to do methylation studies, FISH, and you need to look at an MLPA to detect maternal uniparental disomy. And this is the flowchart of how you can come to a molecular diagnosis with children with Prader-Willi. Management may management. Once you treat their obstructive apnea, you could consider growth hormone. So early growth hormone therapy in children with Prader-Willi syndrome is known to be quite a game changer, but it is very important that the OSA is first addressed, because giving growth hormone can actually further worsen the OSA. Growth hormone regulates their growth, decreases their obesity, and therefore helps the child a lot. So the only contraindication to growth hormone is severe obesity or severe sleep apnea with respiratory compromise. So when would you recommend a CPAP or a BiPAP? If you have a moderate or severe OSA with no tonsil adenoid tissue. So if you do not have a tonsil adenoid tissue causing obstruction, you need to think of using a CPAP or BiPAP. Or if you have a persistent OSA, despite having removed the tonsils and adenoids, children with craniofacial abnormalities, or children with adenoid tonsillectomy is contraindicated, or there may be parents who may not want a surgical approach at all. BiPAP instead of CPAP if there is significant central apnea or hypoventilation, and you need to titrate the pressures, and the titration should be done overnight by admitting the child, by looking at the level of apneas, hypopnea, snoring, and the airflow limitation. Now, this was another case, that 13-year-old who came with seasonal allergies to pollen, had history of sleepwalking episodes since the last 1 year. Initially in the childhood he had infrequent, but now the parent says he's sleepwalking much more. There was no stress which could explain the child's sleepwalking. And it occurs in the first few hours of sleep, and the child has no memory of the events. There was no history of obstructive breathing or snoring during sleep, no other sleep disorders, and there was a family history of sleepwalking in the mother and father during early childhood. The younger brother of this child had night terrors. So how do you manage these call them as a group of disorders which are called parasomnias, and how do you diagnose and how do you manage these cases? So what are parasomnias? They're defined as undesirable physical events or experiences that can occur. So you can have parasomnias in the REM phase, you can have parasomnias in the non-REM phase. So it can occur during entry into sleep, it could occur within sleep, or it could occur during arousal from sleep. It is familial in most cases, and the classification of parasomnias, as I mentioned earlier, could be depending non-REM, REM, and there are a group of other parasomnias which fits into neither REM. I'm not going to go into the details of it because this is a lecture by itself, but I just need to mention that these are all under the categories of parasomnia. So sleepwalking, sleep terrors, you can have hallucinations, sleep enuresis, nightmare disorders are all different forms of parasomnias. All right. Very commonly what we see is night terror or nightmares in children, and we need to differentiate between them. So typically a night terror typically occurs in the first third of the night, and it occurs in children which are between the age of 4 to 12 years. They will get up suddenly crying and screaming, and they're completely disoriented, confused, all right, and they completely forget that they may not even be aware. They will not even remember the event, so you will not be able to they will not be able to recall it. Okay, because they're totally in their sleep or they do not remember, they can actually injure themselves. And the predisposing factors could be a febrile illness, could be sleep deprivation. And most of them, what you need to do is you need to ensure that they are safe. You avoid the predisposing factors like sleep deprivation. A good sleep hygiene is extremely important. And very occasionally, you may need to give benzodiazepines for those children who have a lot of sleep terrors. In contrast, nightmares occur in the last third, in the REM sleep. Okay, and these are children who are fully alert. They get up. They would have a dream. They would remember the dream. They would just get up, and they would have the scary vivid dream present. All right, and since they are awake, they don't injure themselves or they are not violent. There could be some stress or some traumatic event or a personality disorder which can cause it. All you need to them is counsel the parents, and psychobehavioral therapy helps in these children. Most of these children who have night terrors or nightmares, it outgrows with age. So it is parasomnias are more in preschoolers. Most of them decline by adolescence. It can be associated, as I told you earlier, in non-REM or REM sleep, strong family history. Triggers are lack of sleep. Some of them children have restless leg syndrome or obstructive sleep apnea or a fever-like illness which could trigger it. Okay, and frequent parasomnias will need evaluation, and especially if it is associated with obstructive sleep apneas, one may need a polysomnogram to look at these parasomnias. Sometimes nocturnal seizures can present like a parasomnia, so we need to differentiate, and a good video taken by an alert parent will help us differentiate the two. And if it is very troublesome, low-dose benzodiazepines can be used. I think my second last case, this is a 4-year-old who complained odd sensation in the legs and hands more at the onset of sleep. He asked his mother to press his legs or he either shakes them for relief. This is a very common phenomenon. This generation has to actually even press the children's leg, and they press their elders' legs, and also they have to press the children's legs. So, but this is not an uncommon situation when mothers come and say that he's got some sensation in the legs and hands, and it's more at the onset of sleep. So the mom asks you, is this a growing pain? What will you explain to and how will you manage? And what is this? Okay, so this we have a lot of non-parasomnic movement disorders like restless leg syndrome or the periodic leg movement disorders. Most of these children may present with sleep concerns. Either there may be problem with initiating a sleep, or there may be problem in maintenance of their sleep. And many of these children also have behavioral disorder along with these movement disorders. So let me briefly take you through restless leg syndrome. It's also called the Willis-Eggbom disease. This child has an urge to move his legs because he has some unpleasant sensation. So it is very important that you take the history from the child. And the child might explain that I can feel an ant crawling, or somebody scratching me, or somebody's pulling me, or somebody's nailing me. This is the kind of sensation the children will describe. And it has been found that you ask the children to draw what sensations they are feeling, and they will actually draw and tell you. Okay, so these sensations typically begin or worsen with rest or inactivity. It's relieved with movement, and therefore they keep shaking their legs. It is more in the late evening and night. Though it is called restless leg syndrome, these sensations can also occur in the upper extremity. Okay, and you need to rule out all other medical or behavioral conditions to explain these kind of movements. It has been found to be associated with iron deficiency, and doing a ferritin levels and maintaining the ferritin levels above 50 micrograms helps many children, and it runs in families. Children may have associated behavioral problems, may have attention deficit disorders, depression, and anxiety. So this I've taken from Up to Date. If you ask them to draw, this is how the child will draw, because he wants to run, because activity reduces the pain, or this is what the child feels. Somebody is nailing his lower extremities. Periodic leg movements are periodic episodes of repetitive high stereotype leg movements that occur during sleep. Now, these children do not have a problem in initiating sleep, unlike the restless leg syndrome where the children may have problem in initiating sleep. Here, the children have a problem in maintaining sleep. All right, and they may also have this sleep disturbance, and because they have a sleep disturbance, they have an impaired daytime function. The way to diagnose periodic leg movement disorders, you need to do a polysomnogram. If you have more than 5 episodes of these leg movements per hour on a polysomnogram of a specified amplitude occurring at a particular duration, you would make a diagnosis of periodic leg movements. We also need to rule out all other causes of these abnormal movements. Like if the child may have an OSA, he may have extra leg movement. So you need to look at that also when you do a polysomnogram. So I just made a table how you would differentiate a restless leg syndrome, a periodic leg movement disorder, and growing pains, which is again a very common problem in growing children. So here, a restless leg onset is at its onset of sleep or late in the evening, whereas a periodic leg movement disorder occurs in sleep. Growing pains typically occurs again in the late evening, or the child may wake up crying with pain. Here it prevents the onset of sleep. Here it interferes with the sleep maintenance, and this again wakes the child from sleep. Feeling here is uneasy. In restless leg syndrome, child feels uneasy, feels discomfort, whereas in the leg movement disorder, the child keeps on moving the legs. In growing pain, the child tends to have bilateral pain. Generally, it's a bilateral pain. The pain is in the thigh, calf, or popliteal fossa. Okay, ferritin levels are generally low in restless leg and even in periodic leg movement disorders. In growing pains, they have found association with poor bone density, low vitamin D levels, laxity of bones, etc. have been described with growing pains. Diagnosis is clinical in restless leg. For a PLMS, PLMD, you need to do a polysomnogram, and diagnosis of exclusion of growing pains is again clinical with growing pains. Treatment with restless leg, you need to look at iron levels. If ferritin is low, you need to give iron about 3 milligram per kg. If not better with that, or if ferritin levels are normal, other drugs like, and if the problem is quite severe, drugs like gabapentin, clonazepam. It's basically you need dopaminergic drugs, and that deficiency of dopamine is found to be associated with restless leg syndrome. For periodic leg movements, non-pharmacological methods like, for both of these, you can ask the children to exercise, to have a good sleep hygiene, massage, warm compresses are all known to help. So these are your non-pharmacological methods that you would use for restless leg or periodic leg, and otherwise you would try iron or other drugs. For growing pains, massage, heat, analgesics, and counseling the parents is all that is required. So this is the algorithm of how you would approach a child with the in pediatrics of the restless leg syndrome, looking at non-pharmacological methods, doing the ferritin levels, giving iron, and then looking for other drugs if the problem is very severe. So I'd like to conclude by saying sleep disorders are largely still under-recognized, and sleep history is extremely important, and the acronym BEARS helps us get a complete sleep history. We need to train our infants. We need to train our parents. We need to counsel our parents that infant sleep hygiene should be developed very early. Poor sleep is associated with long-term morbidity, not only neuromorbidity, neurocognitive morbidity, but cardiovascular, metabolic, etc. Children with craniofacial abnormalities, neuromuscular disorders are at a higher risk. Children with neurodevelopmental disorders are also at a higher risk of developing sleep disorders. Screening PSG for children with Down syndrome by age 4 is what is recommended. Parasomnias and movement disorders also impact sleep, and when we must not ignore a parent's complaint, and we must dwell upon it and try to see if we can solve the problem. Management depends upon the etiology. It could require surgery. It could require positive pressure ventilation or some medication depending on the cause. So this was like a primer that we gave you between Omi and me on sleep disorders in children. But we are soon coming up with a module from the respiratory chapter of the Indian Academy of Pediatrics. Its module is very nicely coined by Dr. Bharat Reddy as NAPS. It's called Nurturing Awareness in Pediatric Sleep. And we'll be soon launching it on the DIP platform for those of you who want to know more on sleep disorders. Thank you so much.
Indu, if you can stop. Yeah, fine. It was an excellent deliberation from Dr. Omendra and Dr. Indu, and we can see that there are flooding of questions. Dr. Balachandran, sir,
Yeah.
shall I, on your behalf, take up the questions? I think Dr.
Please go ahead. Please go ahead. No.
To take up the questions. So let me, for want of time, I would request the panelists to be dot on the question and answer. So I wanted to finish 20 questions in just 10 minutes. So because everyone has to have their dinner and sleep. So keeping that in mind. Okay. Omendra, for you, you have been in India and UK. We from pediatrics are treating a lot of children with URTI, upper respiratory tract infections. And parents don't want treatment of cold, but they want a child to sleep. You tell me, how do you make that child sleep? Antihistamines? I want a brief answer. What you actually do, tell me. Don't worry about evidence-based medicine.
Yeah, actually as well, I will never give antihistamines for sleep.
Agreed.
So that's not the right answer.
So, okay, what will you do for these working parents?
Working parents, I will just counsel that like sleep will improve as soon as the nasal congestion is gone. So it will take 5 to 7 days.
No, they don't have 7 days of leave. Indu, what will you do in your clinic? Honestly, tell me, please.
We have antihistaminics of the first generation and the second generation. Of course, I would not give it to children below age 2. Above age 2, one could use the first generation antihistaminic, which will serve both the purposes. It will make them probably fall asleep as well and treat their URTI as well. Probably.
Yeah, I will tell you what Dr. Jagdish Chinappa taught me. I'm thankful to him for being his secretary. You know, what he and many seniors like Dr. Balachandran told me when I was joining, these antihistamines will make them sleep for the first dose, but the subsequent doses really disturb the rhythm of the child, and you know, it could be rather gives rise to more sleep problems than before. They would be very happy maybe with the first dose. Anyway, I don't want to make this as any recommendation, but Jagdish, could you also come in? I would be glad to see you. Yeah,
I think the points have been very well taken that you don't give any antihistaminics, but I think I would do two things. One thing I would give is paracetamol, because many times when there is a viral infection, there will be body pain which is not vocalized.
Completely, yeah.
So paracetamol is a good medication to give prior to sleep. The other thing is to keep the nose clear, because many times children cannot sleep because their nose is blocked. So put some saline nasal drops and clear it out before the baby goes to sleep. So if you do these two things, that will help them also.
Can I add?
Jagdish, now that you are on the line, maybe this question is for relevant to you. My apologies to Omendra and Indu. I would just extend this question. Jagdish, tell me real sleep disturbance due to ordinary cold versus the sleep disturbance due to otitis media. Please answer to me in relevance to sleep.
Yes, see, the problem with otitis media is that there is no separation. It's all the part of the same continuum. You can't separate a cough and cold from an otitis media, because otitis media is a part of the cough and cold.
Okay.
So if you look at influenza, almost 40% or 50% of them will have otitis media if you look into their ears.
Okay, fine.
So which means that it's a viral otitis media. It's not a bacterial otitis media, but it is there. Okay. And one thing is there, that we assume that we understand what is happening to the child. That poor child may be having discomfort in his ear, must be having pain in his ears, and he's not sleeping and he's crying. So you need to relieve him of his symptoms. So paracetamol and saline nasal drops, probably elevation of the head to some extent, will give the child much more comfort than anything else.
Okay, fine. Thank you, Dr. Jagdish. Now, Omendra, I have summarized the questions into some kind of categories, and therefore I'm answering. I'm putting that questions into you. tell me, when do you advise adenoidectomy in practice? Very clear messages we want for pediatricians.
So, as I said, the first line treatment is adenotonsillectomy, and depending upon how severe it is, in terms of if there is a preschool children and you see that OSA is not significant, then you can wait and watch as well. But if it is a school going child and has moderate to severe OSA, I would recommend first line treatment as adenotonsillectomy.
So that means you have to categorize the severity and then only objectively recommend.
That's right.
Indu, I'm coming to in India, we can't categorize them. No, not everyone can afford to have some grading. Is it possible to grade the severity and therefore advise in you tell in reference to Indian context?
So I think one criteria is the age. All right, as you said, preschool and school. If you're an older child, you would be a little more aggressive about doing it because it's going to affect his schooling. The other criteria is his severity of symptoms. You may not have a polysomnogram, but if the parent brings a video to show this child is getting up again and again, so that is some kind of an evidence to tell you that the problem is quite severe. All right. So that even without doing a polysomnogram.
No, Indu, I'm interrupting you for want of time. If you suspect OSA, there is no other choice but for them to refer to a sleep lab and get an a PSG done and polysomnography once done. We are clear on adenotonsillectomy.
Correct.
Tell me, for an average pediatrician who cannot refer, what are the indications and how should he decide at least about adenoidectomy? I'm just asking about resource poor setting. I'm sorry for making you not evidence based.
That is what I just said. If this is a child who's very, very symptomatic, even without a PSG, if he's very, very symptomatic, then you would and suppose he has
Can you qualify it further? What do you mean by very, very symptomatic?
So the child is snoring in the night, his sleep is obstructed, he has got daytime symptoms, he's got ADHD, he's developing nocturnal enuresis in the night, he's gasping for breath. So if you have these kind of symptoms, you would definitely consider that you would consider the surgery even without doing a PSG. This is what I would think.
My quick corollary question is: does the lateral neck X-ray decides about adenoidectomy? Yes or no? One answer from Omendra and one answer from you.
Absolutely no.
And I think that should be a very good message. No, Jagdish,
Absolutely
you can come in. Jagdish, you can come in, please.
See, one investigation which has not been addressed is to do a nasal endoscopy. And if you look at the nasal endoscopy, you have clear gradation of the adenoidal size. So you can use that much better than an X-ray or an imaging study.
Yeah.
But again, it's about the resources.
The point is, this has to be taken along with the clinical symptoms, not the size alone. But if you find a large adenoids on an endoscopy, there is an excellent gradation from CMC Vellore, which talks about three things: one, size of the adenoids; two, the choanal obstruction; and three, the obstruction at the eustachian tube.
Yeah.
So you look at all three things together, put the gradation according to that, and then you can take a call whether the adenoid is causing the obstruction or not.
Fantastic answer from for want of time, for the clarity of practicing pediatricians. What Dr. Jagdish is referring to is perhaps the anatomical size of the adenoids and a kind of estimation wherein we can have some objective criteria. And so therefore, on a nasal endoscopy, for the benefit of pediatricians, you can have grade 1, grade 2, grade 3, etc. Almost, I mean, it's just like you remember kissing tonsils, like that you will have in the nasal endoscopy as well. So that's grade 4 and all. So there you would advise adenoidectomy. Now coming back to what Dr. Omendra Narayan and Indu Khosla are referring to is physiology. So if you have an alteration in the physiology, you would advise adenoidectomy. If you have an abnormal anatomy also, you may go for adenoidectomy. Please correlate both physiology and anatomy and take the call accordingly. I think that message is quite simple. So if we were to tell you that snoring during colds is normal, snoring apart from colds is definitely abnormal. So this is a simple message I think that can be taken for the practicing pediatrician. Let me quickly come to the next question.
Can
For want of time, Balachandran, sir, you want to have a comment, please?
Daytime sleepiness is very, very important.
Fine.
Daytime sleepiness, school performance, poor school performance is again a strong indicator for a obstructive sleep apnea.
Excellent, sir. I think they sleep in the day because they didn't sleep in the night well.
Yeah.
So that's the
That's
message.
what Ominan already highlighted. That should be there because I asked them whether the child is doing well in the school in the daytime. That's very important.
So, Omendra, for many questions were asked. Is pulse oximetry a poor man's polysomnography?
I said that, like, it could be a good screening tool. And myself and Dr. Khosla both, we said it has a very good positive predictive value, but a very poor negative predictive value. Yeah. So essentially, if a child is symptomatic, there are some questionnaires as well where you can validated questionnaires. You have videos being shown from parents, performance is being affected. So in that case, you don't worry about polysomnography or oximetry. But if your very kind of resources are limited, oximetry could be the starting point, and there are several oximetry.
This leads me to the next question: which pulse oximeter?
I have no shares in Massimo, but I would definitely recommend Massimo.
Yeah, Massimo.
Because
no, which brand? I mean, which variant of Massimo? Massimo produces from A to Z.
Yeah, so there are different variations. So there are, like, the normal finger pulse oximetry which you use in the clinic is not going to give you the overnight saturation, but you don't. So there are variations where sometimes you can use attached Toscas which monitor CO2 and all. They become more expensive. You don't need that always. What I would suggest is that you can have a normal Massimo radiometer like Mass 6 or 5. You don't need to go for 7, and that will give you enough kind of thing. The reason for
can I ask them, make the question little more straightforward? I'm sorry, I'm not taking the brand names, but most of the nursing homes, I think you have seen India, and they have a monitor.
Yeah.
Can that be used for sleep studies? Yes, no.
Yes, they can be used if they are from the Massimo brand, and you can download the data. What it needs is a software upgrade. That's it.
Yeah, fine. Indu, you want to add any particular point?
That's perfectly.
Only one question.
Please.
If you look at the Massimo technology, it varies almost the same across their pulse oximeters. So for a parent to, if the parent can monitor with a Massimo machine at home, probably the information would be reasonably good.
Yeah, fine. I think we answered the question, but Indu, can you tell me, for an average pediatrician to understand, what should be the pulse oximeter by cost above which he should go for a good sleep study? See, is it 5,000 rupees, 10,000 rupees, 25,000, 50,000 wala, 1.85 lakh wala? See, I'm telling the last limit also, but I'm sorry for this question, but this means a lot for the average pediatrician who's attending.
So I don't think it is the cost which is important. It is the fact that the Massimo technology is the one which has been validated for pulse oximetry. So, and you can take the baseline Massimo, as you said, the 5 and the 6. It's not the cost which is important. It is the technology which is important.
No, but I can't know as a customer how to know the technology. How should I know? From the representative or from you?
No, that the brand Massimo is all the studies are done on that brand.
Fine.
So we cannot look at that is the.
We have a position here.
Jagdish, can you help the practicing pediatrician?
Yes, very simple. Go to the website of Massimo. Okay.
Yes.
Download the entire. There is a full PDF available on their technology. It gives you every model, what it measures, whether only pulse rate, whether there are about 6 or 7 parameters it measures. So they will give you the data on the website. So you can just download the PDF and look at it.
Right now, one of my postgraduate had to purchase the Massimos because I gave her the topic of thesis on sleep studies, which was not given by anyone. So she is into shock the moment she heard the price. Okay. Anyway, that's a different part. Now, Omendra, I'm coming to this question. There were a lot of questions, but I will put them in one line. All these questions were related to sleep hygiene. Okay. So I have summarized it for you to make it easy for you. So children don't go to sleep at all. What they should do? One line answer.
Uh, One line answer is like for younger children, it's mostly kind of environment and the parents. The parents have to have a strict kind of routine, but it's very different for adolescents. And that, so again, age comes into factor. But I would say when we are talking about the sleep hygiene as such, is it right from the room temperature, whether it's too hot or too cold, right
Okay, you
from
answer to me whether AC should be there or not.
weather.
AC
Sorry.
should be there, air conditioner.
Right temperature is the key.
Fine.
Whether
Okay,
you can maintain
fan
with or
on or
without
not.
AC
These,
is
these mothers ask. I'm sorry for making it silly, but can you tell me in one line what is the best way that the parents can put their child to sleep? I've just made the questions rosy for you.
so again, having the same routine is extremely important. So not deviating from the routine, whether it's Saturday, Sunday, or Monday, whether you're school going, summer holidays or not, that that is the key for a good sleep.
So
Okay.
I would add here
Indu,
that
can you tell me 1, 2, 3, 4 for the parents? What they should
yeah,
do?
yeah. So what you need to do is at least a good 30 to 60 minutes prior to the sleep time. There should be no exposure to screen or high intensive activity so that the
Okay.
child's mind is at peace. The timing has to be fixed and strict. It should be the same timing so that the child body naturally also feels sleepy at that time. There should be safety in the the bed. Everything should be comfortable for the child. The bedding should be comfortable. The temperature should be comfortable. You can put soft music if you think the child, it's going to help your child sleep like that. And the environment has to be conducive to sleep. If somebody's playing Ganpati Bappa Moria and you're expecting the child to sleep, it's not going to happen. So all these things have to be taken into
Okay.
account.
Okay. This tempts me to a very small question, but it appears very social. Narayan, tell me, should the mother sing that Lali song or not?
Again, in for infants and children, younger children, that might be soothing, and if they are into a pattern of that, then that's absolutely fine. But you shouldn't be singing for half an hour and 45 minutes. That should be in the first 5 to 10 minutes when they are trying to nod off in their phase one of their non-REM.
And I think most of our mothers knows only first stanza of the song, so it's enough that they could restrict their time. I'm sorry for this letter, but quickly tell me the second question. Is a glass of milk going to produce sleep?
No.
No.
This is what my grandmother told me, so my grandmother is wrong. Okay, fine. Okay, let me come to the next question. So the questions are asked on melatonin. Please tell me when, how much of melatonin is required.
So melatonin is not needed for obstructive sleep apnea, which is your common thing. The use of melatonin is very restrictive for either circadian rhythm disorders or children where you are really kind of want them to, sometimes we use in children with learning difficulties and, cerebral palsy when they're trying really hard to sleep, but they can't. What you have to remember is that it can help you to go to sleep, but it doesn't maintain the sleep. So it's very good for sleep initiation, but is not good for maintenance of sleep. The doses can vary. In younger children, you can start with 3 milligrams. In older children, you can use even 6 milligrams. But sometimes you can see like quite very quick tachyphylaxis kind of thing. Sometimes parents will say that now 3 milligram doesn't work, which was working for them. Now 6 milligram doesn't work, which was working for them. So that happens very quickly.
Hindu Kosla, for the comfort of pediatricians, can you tell me 1 or 2 brand names? Because they would be asking us. Melatonin.
I have never used it, so I don't know.
No, you never
O2,
used it. All
O2,
right.
I think.
All right. Hindu, a specific question for you. Allergic rhinitis child with adenoids. You put them on intranasal steroids. Correct? Adenoids shrink. But when you stop after 2 or 3 months, it is going to rebound. This is what I have read in literature. Now you tell me, will you use steroids again and again, or when you will subject them for surgery? I think you got my point.
Yeah, yeah.
I'm a typical child of allergic rhinitis. This is a very common problem every pediatrician faces.
Yeah. Most of these kids, when you use inhaled corticosteroids, you give it for a period of 2 to 3 months. What is important is you have to avoid the triggers. So if you can identify a trigger, say a dust mite, or say a parent smoking at home, So you have
All these things are done, Indo.
you have
Then
to
you
avoid
relax for a while for you to give relaxation.
yeah.
All these things
So
are
you have
done.
to, yeah, that
But
is one. Secondly,
again he
it,
goes for again adenoids. Now then what will
so
you?
secondly, it is found that generally once you have done a course, the severity of symptoms generally tend to come down with the passage of time. So most of the kids will do well. If it is an allergic rhinitis and not an adenoidal hypertrophy, removal of adenoids is not going to help you.
Fine, fair enough. I think that message is control allergic rhinitis than trying to knock out adenoids. So that's the message that you are telling. I think that should be
Yes.
fair enough
Yes.
from
Yes.
both of you.
1 minute before we leave this question, I think I want to ask Dr. Ominarayan, what is the strength of evidence of inhaled corticosteroids?
Very poor. So they are only from few centers, and it's not a well-designed randomized controlled trial.
So the point is the jury is out still, and probably the inhaled corticosteroids are best used in those children who have got allergic rhinitis with obstructive sleep apnea,
Absolutely.
That's right. Absolutely.
rather than those with large adenoids.
That's
Because
right.
we have seen many times, because of this, patients being given inhaled corticosteroids, nasal corticosteroids for months together for a large adenoid, which doesn't work.
Doesn't
Doesn't
work.
work.
And
Doesn't
also
work at all.
similar thing is for Montelukast as well. And also we should restrict the trial for like 8 to 12 weeks. If you don't see the benefit, then there is no point continuing that.
If you don't see the benefit in one child, next child may not be benefited. I'm just telling you in a sarcastic way. I'm sorry. Okay, I'll go to the next question for you. We have seen many children with neurological problems, maybe cerebral palsy, epilepsy syndromes, autism, so on and so forth. I think I'm not going to tell you. Their mothers beg you for only one thing. Doctor, please prescribe something that my child goes to sleep at least for 12 out of 24 hours. I can take rest. This is a beg from the mothers. This is a demand from my postgraduates. Sir, the night duty I can't do. If such children are admitted, the mothers keep disturbing us. Now, can you tell me what we should do and how to manage the sleep in those children?
So again, the sleep problem in these children are multifactorial. So it's not just obstructive sleep apnea. Even when they have obstructive sleep apnea, the treatment is extremely complex, and many of the time we fail despite various kind of management. And the problem is not just OSA. They have sensory issues, they have tone issues, they are very dystonic. So, they can have pain. So sometimes, melatonin can be helpful in these children for at least the initiation. And then you might have to adjust the dose of, they might already be on chloral for their dystonia and things like that. So you might be asking your neurology colleagues as well that is there anything else that can be optimized. But just removing their tonsils is not helpful. Just giving them intranasal steroids is not helpful. They have extremely poor compliance with oxygen or any positive pressure machines. So it is a challenging kind of population, and there isn't a very easy answer for that.
There is no straightforward answer. How you were managing in your nursing home such children when you admit them?
So
And they
again,
disturb you with
I
different
think
phone calls.
these are children who require a multi-pronged, multidisciplinary approach. They might
Which are the
require
other disciplines you will
therapist,
involve?
so like an occupational therapist, and sometimes these children may require some psychiatric medications as well, because some of them may be say something like a risperidone, etc. If they are very hyperactive, very aggressive. So I think this requires a multi-team approach to manage such children, and it's a very complex situation. It's not as simple and straightforward as one may think it to be.
I think what you are telling is there is no Brahmastra that we can give and get away from these children. Can we take that as an answer? So
Yeah, correct.
Yes.
absolutely.
that's the message
That's
that
the
comes
message.
out, I think, from all of you.
Yeah.
Okay, Omendra, this is a question which was very interesting. Like we have some scoring systems being given for parents. Is
Yeah.
there any sleep scoring for parents to be given as a leaflet that they tick and I know that this is a problem with the child, this is a problematic child?
So there is one of the most validated and widely used is PSQ, which is I think Indu mentioned in her talk as well, and that is the most validated one. In adults we have several validated scores, but in pediatrics we don't. And that in that there we have like 22 questions which you ask, and generally is filled by parents, because you're asking about, does your child snore, how often do you snore, what's the daytime activity like, and then it's based on that. So we
Can you share that for us? I'm going to send it to all the participants today. Let them at least have a kind of look and then see if they can offer it in their outpatient to the
absolutely,
parents.
absolutely, it can be done, but it takes 5 minutes.
Fantastic. So, role of genetics. Somebody was asking if one child sleeps, is it that the other child sleeps? My mother used to tell me, girl, you should be blessed to have a girl child which will sleep. If you have a boy, he will trouble you a lot. I mean, tell me something about genetics.
If you look into the data, essentially boys and girls have pretty much similar kind of numbers. Uh, so yes, there is some ethnicity which is, which can be more prone for OSA, but there isn't as such variation between boys and girls. It's pretty much equal numbers. Would you agree, Dr. Khosla?
Absolutely. I don't see there's any difference here between a girl and a boy at all.
Okay, is there some family that sleeps very well, Kumbhakarnas kind of thing? Or is it that some families don't sleep well? I'm just asking the role of genetics. Again,
So again, it can, as we said, there can be lots of variation in your mid facies itself. So
okay.
in if you see the North Indian population, and if they are from, they are tall and they have tall nose and long nose, they might have less kind of facial flattening and less obstruction due to even with adenoids. So we see that when we see Afro-Caribbean kids, they are highly kind of prone for obstructive sleep apnea just because of mid-facial hypoplasia. And when they get enlarged adenoids and tonsils, they are in problem.
So you mean to say we from South have problem and definitely somebody from North and Hindu is in central part of
No,
India. So
I didn't say
no, I'm
that.
okay. I'm just trying to, pull you. No, Hindu, tell me.
Other thing is, if there are family history of psychiatric disorders, anxieties, and those are people who will have more problems in initiating and even maintaining sleep.
I
So
think
that can be.
yeah, fantastic. What Narayan was telling is that the relative size of the airways compared to their facial anatomy. Fantastic point. It's not that how much of obstruction we have, it is actually how much of passage we have got for the air to go, rather than looking at what are the obstacles that we have got. I think that's the message, and a fantastic message from you. Indu, tell me, what will you do for Jagdish, you want to come in, please, please.
Yes, one question, Dr. Indu Khosla, this is for you. You mentioned about the dental abnormalities which we see. The issue is, are they the cause or the effect of obstruction?
So it can be both. It can actually be both. You can actually have an orthodontic problem in the first place, and that can have lesser space in your oral cavity, and that can cause obstructive sleep apnea. And children who tend to have enlarged adenoids will have adenoid faces, and then will have secondary dental problems. It can be both. So you can see what started first. What started first would tell you where you are.
I think the point well taken with what Dr. Omi mentioned was regarding midfacial hypoplasia, but also we need to understand the role of the mandible. If you have retrognathia, you have the same thing. You have a reduction of the posterior pharyngeal.
Absolutely agree. We sometimes see normal children with massive retrognathia, and they have extremely bad OSA, and you run in trouble.
I think Dr. Balachandran is quietly smiling and is seeing that in our times we didn't have any problem of sleep, appetite, or bowels, anything, or stress for that matter. And it is the younger generation that is trying to squeeze something out of normal lifestyle and making everything abnormal, and we are struggling. And thanks to COVID, do you agree?
Yeah.
Making our lifestyle normal. Balachandran sir, one comment from you from your experience-based medicine, Are you seeing any difference in the spectrum? Is it because that those problems do not exist, or is it that these problems are de novo or they're getting recognized now? I mean, small question for you, because I need some inputs from you from your years of, seeing so many patients.
No, not much. Those days also we used to refer them to a dental problem. When you refer the case to a dental surgeons give us a feedback also. ENT surgeons will give us feedback also. These are all the people who, those times, more than the pediatrician, we used to refer them for any problem, job problem, we refer them for dental surgeon, any ENT problem, the ENT colleagues will give us. So we also learn from them. But we now, as a pediatrician, we learned ourselves many things, and we also share their ideas also now. Each and every time, those days, like, all the cases were, whether they are adenoid or tonsil, they will be sent to the ENT pill, they will knock it off. Nowadays, we don't do that like that. We don't, all the pediatricians has got a rational. When I want to send it as a tonsillectomy, I'll think twice, thrice, whether this child they definitely get benefited only, I will send it. Otherwise, those days itself we have been breasting, but
Yes, I
other
think
GPs will be sending them.
the kind of approach of multidisciplinary, the available disciplinaries were used than the kind of dedicated disciplinaries which are available in the current time. Sushant Mane, because you have been quite for long time. Sushant, do you see sleep problems in practice, or you all your mothers and fathers are very, very happy because you are being quiet? So I'm just pulling you into that.
Especially as the knowledge has grown over these sleep things, we are actually using what Madam said, the bear score. We use that in our OPD. If we get a child where the mother predominantly...
Sushant, let me ask you a very straightforward question. I don't have time to ask how many times you cough, how much of fever you have. Will you ask that bear, tear, tiger questions and all that in your practice? Is it
If
possible?
the mother is complaining of a sleep-related issue,
Then only will get in.
Then we definitely go. That is one. And second time, if we have a child who is coming with a recurrent URTI, which is most commonly we see, and we don't often correlate it with, why this child should get a recurrent URTI or why is this child coming up with recurrent problems. Only particularly those category of patients who would put up that bears question.
So I think this question made both of the specialists in sleep to think twice, the knowledge of sleep that is required for an average pediatrician in our country. I'm just trying to bring out the spectrum of thinking, and therefore that gives birth to a fantastic module. Please wait for it. It's going to come from Indian Academy of Pediatrics Respiratory Chapter. Jagdish is smiling. We are almost into the end of the module, and it is going to be released very soon, and you will all enjoy a wonderful module from the Indian Academy of Pediatrics Respiratory Chapter. Before we would try to close, I will just ask one final remark from each one of you. But let me tell you a few things, because the viewers may just go off. Next Monday, 9 p.m., we have session from Dr. Professor P.K. Vedantan from US. He's a fantastic senior. He's from our own part of India, who has years and decades of experience in asthma and allergy. A wonderful human being, an excellent clinician. You will have a mouth-watering sessions from him next Monday at 9 p.m. Please respond to my WhatsApp messages and from others. And lastly, I would thank Dr. Jagdish Chinappa for being with us, Dr. Sushant Mane for taking efforts, Dr. Balachandran sir, it was pleasant to see you. I think after this we can sleep comfortably.
Yes.
It was so nice to see you as a senior most coming to our platform, and a smiling youngster. I think Omendra, we would invite you to India. You can tan a little bit. You look more British now. So please come to India quite frequently and share nice time with us, Omendra. It was wonderful. It was nice to know that you are dean and in charge of sleep medicine in UK. And what a great honors and what a great achievement you have done. And I do understand that we have not done justice by giving you just 30 minutes, because what if you want to tell, I think everybody will have to be awake whole night, and that would be next to impossible. And I can see Indu pushing with time, as much as possible, and that speaks volumes about our commitment. Let the pediatricians know as many cases as possible. Lastly, my last comment before all of you would pass one comment each. So I will have one comment from Omendra, final one word from you for all our viewers.
I would just say that keep in your mind sleep and healthy sleep hygiene. That's it.
Okay. Indu, one liner from you.
The old time proverb of early to bed and early to rise makes a person healthy, wealthy, and wise is very true.
Healthy, agreed. Wealthy, I don't know how. Okay. Jagdish, because people run clinics up to 12 o'clock. Okay,
I will
Jagdish,
reserve my
one
comment
line
for
from you.
last. Let's ask Dr. Bala and Sushant to, and you talk, then I'll talk in the end.
Okay. Balachandran, sir.
Sleep hygiene is a very important thing. As they all said, the quiet environment of the child is very important. All the people should stop everything sound, everything should be low, light should be low, and the child, we must make an effort that we are going to sleep. The bedroom should not be a punishment room. That's all we can. I will put you into the room like that. Nobody should threaten. So sleep is an important thing. Hygiene and all, this step should be put into their mind. Sleep is essential. That's all to the children. That's very important.
Sushant, one word from you. Excellent. Or we congratulate you first for bringing such an excellent science to all of us. No, and one line from you.
As you, Subbu sir said that we should not sleep over sleep. I think nobody has slept over sleep. You know, the discussion has shown that we were so attentive and we are ready to learn. So my thing would be, from respiratory chapter, we are bringing all these novel ideas. Thanks to Subbu sir and Jagdish sir. Please join us every Monday so that we can exchange knowledge with all of us. And a virtual hug to Omi, because now he's not in India.
Okay. So one
COVID
line.
time, so contact distancing
Yeah.
is important.
Yeah. One line for me is that I will thank ClearNet for sponsoring this. I mean, for giving technical support for us, and they have been standing by us. And thank you for joining us in dissemination of the knowledge. As secretary, I will tell you. Do you want to know more about sleep? There is only one way and one medicine, one drug, and one investigation. You don't have to invest 1.5 lakhs in pulse oximetry, or you don't have to refer to a polysomnography also. There's only one solution for the sleep. Can I tell you tonight? Become members of respiratory chapter. You will learn everything. Your whole life becomes easy. You will never get night calls. All your URTI, LRTI, pneumonia, asthma, management, everything becomes good. Your parents sleep well, your children will sleep well, and with the knowledge, you will also sleep well. So just pay 2,500 rupees. I will send you the membership form tomorrow itself to your WhatsApp, and that's it. As secretary, it's inevitable for me. Please become members of the chapter. So that's the final word from me. Over to Dr. Jagdish.
Thank you, Dr. Subbu, and thank you all of you, Dr. Omi, Indu, Sushant, and Dr. Balchandran for coming in here today, and of course our fantastic audience and ClearNet for helping us out with this excellent program. I think today was not a scientific lecture at all. It was fun time, and I think we had a wonderful time with our two speakers who just went through various aspects of sleep and just kept us entertained and awake both. The last point which I wanted to make was that in everything else, boys are supposed to have an edge over girls in our country. But as far as sleep is concerned, it's always Soja Rajkumari. And so with that I end, and it's same everywhere. It's Sleeping Beauty. It's Soja Rajkumari. You see, so thank you very much for this wonderful evening, and it's been absolute fun through the last 2 hours. We didn't know how time went, and thank you very much. We see you soon. Dr. Omi, also see whether you can partner with our respiratory chapter and try to push the sleep agenda in India much more than what it is today. Thank you very much.
Absolutely, sir.
And thank you all.
Thank you.
From the IAP Respiratory Chapter, and good night, and have a good sleep.
Yeah, thank you. Thank you.
On behalf of ClearNet, I would like to thank all of you for joining in today. It was an absolute honor hosting all of you. Thank you so much. Good night and stay safe.
Good
Thank
night.
you.
Bye-bye.
Good night.
Bye.
Are we offline?
Yes, sir. I'll just turn it off.